Thank you. Good afternoon, everyone, and welcome to our afternoon session where we're going to be talking about, we're going to be having a conversation about where things stand in terms of marketplace implementation now in our second open enrollment period. And we're going to talk about how far we have come in the last year and how the second enrollment period has been going, and where we're headed over the course of the next year as we're bound to see some additional changes now that we have been through 2 open enrollments, 2 initial enrollment periods, and 1 renewal period. There are going to be a lot more changes this year. We have a year full of firsts. Now we are 3.5 weeks approximately out from the end of the second open enrollment period. There have been, I think, some really remarkable changes, what a difference a year makes from when we were sitting here last January and things weren't going so smoothly as they are now. I think one of the things that distinguishes the open enrollment period this year from last year, frankly, is the lack of news about the enrollment process. There's been news about the number of people signing up. There's been news about renewals. There's been news about process, but very little about the enrollment itself. And one of the reasons for that, I think, is because things are going much more smoothly than they did last year, all in all. And that's really good news. And so we want to talk a little bit from different perspectives of the panelists here with me today about what is happening and what we should be looking forward to as we move ahead. So let me go ahead and introduce our very distinguished panelists. First, we are joined by Kevin Cunahan, who is the Director and Marketplace Chief Executive Officer at CSIO and CMS. Thank you so much for coming.
Thank you.
Kevin comes to us actually from Connecticut, where he established and ran the Connecticut, very successful Connecticut Marketplace. Met some friends from Connecticut here.
Right.
And he also has extensive experience in the Massachusetts Exchange. So he's done fantastic work. After Kevin, we're going to hear from Mila Kaufman, who is the Executive Director of the DC Health Benefit Exchange Authority. And we are not sitting in order, just so you all know. So I'm going to be looking all around me. Mila is, as I said, the Executive Director of the DC Health Benefit Exchange Authority. She has had extensive experience in health policy and insurance oversight, both as the Superintendent of Insurance in Maine and the faculty of Georgetown University Health Policy Institute, and she has an incredibly long bio, so I'm not going to do her at all justice. But we are very pleased that she is here to join us today to talk about what is happening in the DC marketplace. I've got out of order here. After Mila, we are going to be speaking with Bill Hazel, who is the Secretary of Health and Human Resources in the Commonwealth of Virginia. And he is distinguished by having had that role for 2 governors, 1 Republican and 1 Democrat, and he's done amazing work in Virginia. And then we are going to hear from Catherine Tier, who is a project officer at the California Healthcare Foundation, and she's going to be talking to us about some research that the foundation has been conducting about the consumer experience in the enrollment process. I think is going to be really informative as we think about how we are doing and what we need to improve in order to make sure that we can do an even better job going into the next open enrollment period. So the way that we're going to structure this conversation is that we're going to hear from each of our panelists, and they're going to give us about a 5-minute overview of sort of where they're coming from and what their experience has been. And then we're going to have a little bit of a discussion up here, and then I'm going to invite you all to participate in the discussion by writing down questions that you have or comments on the cards that are at your table. At some point during the session, there will be people coming around to collect those cards. So as we're going along, if you have a question and you have a card that you want to hand up, you should just hold it up and someone will come around and collect it. So why don't we go ahead and get started. I'll maybe turn to Kevin, and you should give us a few remarks about what it's like to run healthcare.gov.
Okay. Well, it's a new experience every day, so it's hard to say. But what I would say is the following. First is I just want to thank all of you for the invitation to be here. You know, this audience represents our sales force. You folks have all gone out into the field to help enroll people. You've dealt with some of the complexities, obviously, of a year ago, and you've been very patient as we've tried to work some of the bugs out of that type of process. And I just want to let you know, from all of us at CMS, just how grateful that we are for all that you've done and for all of your work. So I appreciate that. And I got to reacquaint myself with some of my old friends from from the Constitution State, which was very nice to see, and they are great examples of that type of commitment. I think you're right. I think this year has been a better year for people. We've tried to make the enrollment experience simpler and easier. We've reduced the number of enrollment screens from 76 down to 16. For those people that are renewing, 90% of the renewal application is pre-populated to try to make that a little bit easier. The site is warmer, the fonts are bigger. We're learning. To be frank with you, we view this as just one big bit of continuous improvement. Every year we're trying to make this better and faster and smoother and easier for people. And we've got a ways to go. Our infrastructure is getting better. It's not where we want it to be yet. Decision support tools. We need to do more to help both you and our customers navigate the different choices that they have. So we're very committed to that. Insurance literacy. You know, it's been interesting when you talk to our call center, and we've got about 13 to 14,000 call center representatives. What they've told us is that this year they're seeing a marked difference in the types of questions that customers are asking versus a year ago. So their familiarity with things that we all take for granted, such as deductible and coinsurance and copay and those things, they were asking about those last year. Not so much this year. They're getting more sophisticated with respect to talking about network size and different types of products. Choice is something that I think we have to actually think about. We've spent so much time getting more issuers in. We've got 25% more issuers on the exchange than we had a year ago. But we're offering a lot of plan options in many markets. And one of the questions that we're getting back, and I'd be very interested at the right time from hearing from everybody in this room, is, are we offering too much choice, right? There's this book called The Paradox of Choice. It's right, and it's like you interview somebody, they all say, I want unlimited choice, but when they actually are given unlimited choice, they actually prefer to have more finite choice. So we're trying to figure out, you know, how to balance that. We're trying to work with the issuers to open into new markets. But I would tell you fundamentally, I think what's so different from this year, from my experience, and this could be in Connecticut or it could be here, is I think this year we're beginning to understand for the first time the real details of the ACA from an administrative and operations perspective. Last year, and I'm not minimizing last year, please, but was so much about web functionality, it was about enrollment, it was about marketing, it was about building that type of process in those systems. Now we're getting into such things as the 3 Rs, administering co-ops, the tax issues. We're making great progress, by the way, in terms of on track for getting the 1095As out. But the tax season is going to be clunky. It's going to, because this is new. And you know, people are going to have good questions, and we're going to, and you know, we're working with the IRS to make sure that we can answer them, but it's going to be new and different. And even though it's going to, you know, the questions are going to impact the minority of folks, it's just going to be new and different. So I fundamentally think that this remains a 5-year implementation. We're really at the bottom of the first year. And I fundamentally also believe that every year it's going to get better, and it's going to be more routine for people. And in a couple of years, this is going to, 2 to 3 years, this is almost going to feel rote. Not exactly necessarily, but it's going to give us the chance to start working on quality metrics, start thinking about insurance education, about how people can be better consumers, give them better information, work on the kinds of things that, quite frankly, get away from some of the operational components. Will there always be a key focus on operations? Absolutely. And we are very driven. And I can tell you, the secretary she drives us very hard on improving the customer experience. And we take our cue from her. And she's very, very consistent on this. So I'm not trying to sugarcoat. I'm not saying everything's going the way we want it to do, but I think we're making progress.
All right, thanks very much. Mila, do you want to talk a little about the DC experience?
Yep. And I have slides.
Great.
Should have known.
Because I want to share some data with all of you. Can you hear me? Okay. So first, I want to say thank you so much to Families USA for inviting me. It seems like it was just yesterday when Ron and I were doing a joint press conference on October 1st, 2013, and DC was one of the four exchanges that was up and running on time, and we were so proud. At that moment, we knew we were a major part of history, and nothing has really changed. We're all still part of the same history, and so it's an honor and really a privilege to be here with you, because all of you work so hard every day to make sure that every single person out there who wants to be covered is covered. So thank you. It's great to be here. I just want to say a couple of things about my board. We are a private-public partnership. I have a private executive board, and we have many stakeholder groups that we work with, including a standing advisory board, and actually Claire McAndrew from Families is vice chair of our standing advisory board. So here's the data slide, and we haven't made this public, so you're the first to see the most recent data for us. From October 1, 2013 until just earlier this week, we've had over 75,000 people come through DC HealthLink. DC is a very, very small jurisdiction, so these numbers are actually quite huge for us. We've had over 19,000 people enroll in private individual health plan coverage. Over 40,000 have been determined eligible for Medicaid. We have one no wrong door, essentially. So people who want to figure out if they're eligible for Medicaid, they come through DC HealthLink. And on the shop side, the small business side, we've had over 15,000 people who've come through us and are currently insured through us, which includes Congress. We have the privilege of serving members of Congress and their staff, including their district offices. We're very proud. Just in our first year of operation, we think we've cut the uninsured rate in almost half. We surveyed our Medicaid and private population, and we found that 43% of our enrollees did not have coverage before. We've made a huge dent. We started with about 42,000 people uninsured, and we think we've covered almost 19,000. And of course, we're not going to stop until every single person who lives and works in the district has coverage. So we're very proud just in the first year of existence what we've accomplished. We have lots of choices. Some people question if it's too many choices, so we're always struggling to figure out how to improve our search engine to make it more manageable for both businesses as well as individual consumers. On the business side, we have 193 different products, and on the individual side, we have 31 from all of the major insurance companies that do business in this region. We have a relatively young demographic. We started with the data point that 60% of our uninsured population were under the age of 40. So in the first open enrollment, we really focused on the younger population, and you see the result. The biggest category of covered adults is 26 to 34-year-olds. That's 39%. We also have people choosing at all levels, so we're different from the other jurisdictions in that we have significant enrollment in platinum and in gold coverage, along with silver and bronze. Bronze is the highest, and by the way, the President of the United States did enroll through DC HealthLink last year, renewed this year, and he chose a bronze plan, and I'm convinced that others follow his lead, so that's the biggest category of our enrollment. Our small businesses are quite choosy as well, and most small businesses want the best benefits, lowest deductibles, and they're willing to pay the higher premiums, platinum being the #1 in terms of covered lives on the small business side, and gold being the second. That does not include congressional enrollees. We have full choice, and employers are taking advantage of choice and offering multiple carriers and multiple products. And I'll just say a couple of things about our success. We wouldn't be successful if it wasn't for our ground game. We have partnerships with community health centers, with consumer advocacy groups, patient advocacy groups, businesses, and we're very, very proud of those partnerships, and that is the reason why we've been successful to date.
Thanks very much. Secretary Hazel, you're in a little bit of a different position, not running a marketplace, but participating in the federal marketplace. I wonder if you could talk a little bit from your perspective about what's going on.
I think I am in a different position. We had a lot going on in Virginia last year, and I think we have to go back to understand our experience. You actually have to go back to 2010 when the bill was originally signed, and it was clear that in Virginia, no one was going to take any of the PPACA money to do anything. And so the question then is, if you're secretary, how are we going to relate to a federal exchange? And at that point, we thought Medicaid was going to be mandated, so how are we going to get ready for that? So that was really, I think, the genesis of the 90-10 money when we were talking to the folks at the White House. So what we set out to do is a little different. We set out to set up an eligibility system to get ready for MAGI. And with the idea that that would be our gateway into whatever the exchange turned out to be in Virginia to try to get that to work. Now, when you think about a major system, we also didn't want to do a system that was just for Medicaid, because the population, obviously, probably 50% plus, 60% of our individuals in SNAP also are Medicaid recipients. So we're looking at combining the eligibility system. So if anyone has been on 95 south of Washington recently, or any major interstate, when you've got one lane closed, that's what happened to us last year when MAGI went into effect in November and open enrollment happened. And interestingly, we did not expand Medicaid. If anyone here doesn't know that, you know, I'm afraid my current boss is going to fire me because I still haven't been able to get that to happen. But so what was interesting for us, we had a 62% increase in our Medicaid applications without an expansion. Now, we knew we were going to get applications, but we didn't realize it was going to hit us that hard. So I've got a lane closed on the interstate, and the traffic went up over 50%. And our local agencies drowned. I mean, really, we're drowned. And then on top of that, our friends at the FFM sent us over 60,000 applications. When they finally came to us, we had 60,000 more. And we've just cleaned up the lion's share of those. And so the challenge we were facing is those that came down from the FFM were generally not in very good shape. And at one point, our team said it took an hour to process every one of those. And so the lessons that we were learning is, well, number one, is that we really wanted to be sure, whatever happened, that we had a better way of stratifying who got into what. Of those 60-some thousand that were sent down from the FFM, very few, I think probably less than 10%, actually turned into Medicaid coverage, and a number got sent over for ABD determination. So it was a real challenge for us to operate. So a couple things that we did. The other thing I will tell you is we were in the middle of our state gubernatorial election last year. So you had the outgoing governor, my previous boss. We had done nothing in terms of marketing. We had no real interface at all with the FFM. And then comes Governor McAuliffe in January. And as we got ready for this year, we've done a few things. One is we had some carry forward money that Society let us repurpose to purchase navigators that live at the Virginia Poverty Law Center and RFQHCs around the state, about 100 bodies to help. We got some additional money, about $9.3 million, to do marketing, which we had not done before. We've got TV, radio, social media that started with open enrollment this time. Now, all told, last year, without anything, 216,000 Virginians signed up. Now, to give you an idea, we have 8.3 million Virginians now. We estimated, we had prior 1 million on Medicaid, probably 1 million uninsured. So out of that, to give you some, we figure maybe 8+ times your population, we got 216,000 with nothing. The governor has given us a goal of 160,000 newly enrolled that we're getting through. What I can tell you as of last night, I think the numbers you all sent us, we have 316,000 plus enrolled. We know that over 100,000 of those are new. It's hard to know exactly right now how many are renewals, so we think this outreach has helped. One thing that we did is we used some funding to improve our famous website for Cover Virginia so people could come in and basically get a calculation, and we would send them to the FFM or send them to our site in order to try to reduce that duplication. And whether it's worked or not, it's a little too early to tell. Probably 35,000 folks went through that process. So a lot's going on. Big problem that I see for us is what happens if the Supreme Court says that you can't do this anymore. And I think that's something I'd like to chat with you about here before we're done, because you're going to need your help to fix it.
I have great expertise in that area.
You now have this great system. Can I rent it from you cheap if I need it in a hurry?
What? I'd love to talk.
All right, great.
My time is up.
Oh. So, I'm going to go over here. Okay, so Catherine's going to come over here, and we're going to talk a little bit. I mean, Catherine, so your perspective is more about the consumer experience, and we know that's changed a bit from the first open enrollment period to the second open enrollment period, but hopefully you can tell us a little bit more about how consumers are faring.
I hope I can. So first, I'd like to say I'm just very happy and honored to be here on this panel, particularly with all these esteemed colleagues who actually have the responsibility for implementing things, which I do not. But what I'd like to talk about today is about the consumer experience, and specifically about some consumer-focused research that we've been engaged in that I think will be of great interest to all of you here. And I'm going to start by letting a few other people speak before I do. What I'm going to do now in just a second is play some clips of real consumers applying online for health insurance during this open enrollment period, applying either via state-based online marketplaces or healthcare.gov, both. And these are people who are either in the process of renewing or in the process of applying for the first time. And in our research, we watch them as they are sitting in front of their computers. We watch and record them, and here are just a few clips of the results.
I want to get right into the application so I can move forward and see what I qualify for. You know,
Okay.
And then it gives me an option of logging in, and I'm like, okay, I don't have a login. So I guess I'm a little confused here.
So I think compared to last year, this year was great. I feel way more confident this year than what I did last year about how I navigated the website and how I was able to choose everything.
You know, it's asking for other household members' information, which would be my roommate, but she would have nothing to do with this. You know, I don't have her social security number or anything. Yeah, because they want like all of her information, which I have. I just don't have her social security number. Or I could just text her and ask her what her social security number is.
Well, I thought they wanted next year's income information. So, and now they're asking me for the first date paid. So I'm assuming they want, I guess, my current job, which I wouldn't know what to put because I work for many different people. So I wonder if I can leave it blank.
That's why the income part is so hard for me. This is the hardest part to figure out. And also what I don't know and what I would like to get help with is what would happen if I show my income low here and qualify for some plan where I get help from the state. But then at the end of the year, it turns out the money I get from the market, from stock market, is higher than what I would qualify for the discounts. What's going to happen? Like, am I going to be asked to pay back the premiums, or is there going to be a fee? And that's not clear to me.
I was just going to say that's a little frustrating because a few pages back it says it'll show you your health plan and show you exactly how much before you buy. And like right here, it's talking about the results provide an estimate only. You will see your actual rate once you complete the application. I'm like, what? That's just totally contradictory to what I read before. So at this point, I would like get frustrated and probably exit out.
So hopefully you could hear those. You know, you hear a mix of confusion, appreciation, frustration, some more confusion, and we have seen a lot of that. So let me tell you a little bit more about this research. In collaboration with the Robert Wood Johnson Foundation, our foundation, the California Healthcare Foundation, is in our second year of real-time user testing of the online applications. And this research has produced and is continuing to produce real actionable findings, and partners, including our colleagues at healthcare.gov, have found that the work dovetails well with their own analytics and the research that they're seeing. The work is being conducted by GoToMedia, which is a San Francisco-based company specializing in user experience research and design. And this time around, the researchers at GoToMedia have spent now the last couple months doing a screen share process with real applicants and listening to them and trying to probe for where they're getting hung up and just kind of watching them go through. And the research is still ongoing. We won't wrap it up till the end of open enrollment, so we'll have more detailed findings then. What the research lets us do is really get at the why. Why people like parts of the site, why they don't, why they're guessing in places, why, as you just heard someone say, I guess at this point I would just quit. And this kind of direct observation really augments other kinds of research like focus groups or post-enrollment surveys or the kinds of call center analytics that I know my colleagues up here are using to do their own analyses. So of course, online enrollment is just one channel, but this kind of research into consumer experience and user experience is really important across all the enrollment processes, whether it's online or assisted or enrollment at provider sites. Why? Obviously because we want to improve the experience that consumers have. We want them not only to get enrolled, and that is obviously the number one, but beyond that, to come out the other end of the enrollment process knowing a little bit more than they did when they went in, knowing a little bit more about what a deductible is, or really understanding how to use their insurance. So we want it to work for them. But equally, we understand that a good consumer experience is really absolutely necessary for the marketplaces to be sustainable and to be efficient. You know, I mentioned earlier people guessing about what to put down, and you heard someone not sure whether her roommate was a household member for the purposes of her application. Well, in doing this work over the last 2 years, we continue to see and have seen a number of people who just can't quite get the household definition part and end up qualifying or thinking they're qualified for Medicaid and moving over to Medicaid when in fact that's not what they're eligible for. So I think we all know the costs of that kind of misdirection. So everyone up here, everyone in this room I know recognizes the need for continuous improvement, and obviously that is an iterative and ongoing process. We don't get it right once. But this research can really be an important part of it, and I'd be happy to discuss it more and looking forward to the conversation.
That's great. Thanks so much. So it seems like we've been sitting here for, what, 4 or 5 years now talking about implementing marketplaces. And we started this conversation talking about what it took to create your board if you were going to establish a state-based marketplace, and what were the different rules that need to be in place for oversight of the marketplace, and how are we going to attract insurers, and what kind of technology do we need to put into place, how are we going to design an application. There were a lot of different nuts and bolts that we've put into place over the course of the last 5 years, and our conversation has evolved, and it feels like at this point we've actually got most of those nuts and bolts in place, and it's time now to have this conversation about the consumer experience, because a marketplace isn't just a website, a marketplace isn't just a shopping zone. It's actually made up of its participants, and that consumer experience seems to be very crucial in making all of this work. So I want to just talk with each of you to maybe share some thoughts that you may have about what are the most important improvements that we need to be thinking about at this point in order to improve that consumer experience as we go forward. I don't know, Catherine, if you want to start, given some of your observations.
Yeah, sure. I mean, the first thing I would say is that, you know, I want to make sure to recognize that from a technology perspective, from a functionality perspective, things are a lot better than they were last year. So the kinds of things that we might have seen last year, people just getting hung up on pages or being timed out, a lot of that is working better. The channels are flowing, and that's a big achievement. The continuing pain points, obviously we chose the audio clips to try and illustrate some of them. Income calculations are very, very difficult, and that's, you know, there is not, it's not that design alone can make them simple, but design and better tools and better explanations can help. part of that is counting household. People really have a hard time understanding what their tax household is. Plan selection is a really difficult nut to crack. People, as Kevin said, there's a question about how much people can compare and how many choices they can really manage, and it's, that one is not simple. And finally, I think you know, people want to have a smooth experience where they feel like they're supported and where they can have trust in the application, but that carries over to trust in the product and trust in the sense that, you know, when they go to online chat because they're not certain that someone's going to be there right away. And so there are pieces like that. And that's just on the online side.
Yeah.
No, I couldn't agree more. I just feel like we just have to do more to make this simpler. And buying health insurance by definition is confusing, complicated, and expensive. And so I you know, feel that, you know, it's like this sort of, you know, Piaget, you know, tower of need. You know, the first is to make the thing work, right? You know, and we've got to then just raise the bar so that we educate our consumers, but also just help them navigate these choices and make it simpler. You know, one of the things that we've done in my old state and some states have done is they've had some standardized plan designs that everybody had that made it, you know, so people had that option, and then the issuers then had the chance to put some customized plans by metal tier in addition to that. I'm not saying that that's necessarily the answer, but I think to the extent that we can make it simpler for people to understand what their benefits that they're comparing, what the networks are, and what the formularies are, all those things are part of, I think, the next phase for us to try to reach that goal of more simplicity.
Bill, do you have any observations there?
Well, there are a couple things. The first thing I can tell you is that the folks who came in through our federally qualified health centers that had a certified application counselor help them with an application. The biggest point of dissatisfaction is 70% of them were told no, they made too much money because we didn't expand Medicaid. So getting a better outcome for them, that would help. That's not an exchange problem, but it's a problem. I think for us, having sort of set it out last year, and then also, I'm guessing that I'm like this for all of the ones where you all are managing. There is, you all are busy doing what you're doing, and so at some point, we're going to need to get some feedback on what is happening on the ground. We can't help without a little bit more knowledge of what you're doing, how you're doing, and yeah, I think everyone's been good to work with. I'm not worried about that, but I think that particularly now, because if the Supreme Court does throw out your exchanges, we're going to have to be able to pick that up. And we're starting from zero, and all of those states like us are probably starting from zero. We did a lot of work in Virginia, in fact, figured that we would actually build a state exchange until the politics became such that we couldn't take that money. So we thought about how we would govern. We did keep the insurance function, which was good, but for us. But at this point, we're going to need some quick training, and I'm guessing that there are a lot of states in the same boat that are going to have a contingency for the court decision.
So a couple of early lessons for us. We learned that, and from day one, we had most of the functionality online. And we learned that for most of our individual marketplace customers, most people could go from start to finish, no problems. In fact, I've talked to some consumers who said they did the whole thing, application and plan selection, in 15 minutes. Which is great. And then some customers couldn't go through. Is this better?
Yes.
Yeah. Okay. So the take-home message from lesson one is most of our customers during the first open enrollment can go from start to finish, completing their application, making their plan selection in 15 minutes. No problem. Then we had a category of customers who got stuck because of IT. And those were pretty much miserable experiences for our customers. And we've done a whole lot to change that. And then we have a category of customers who don't have a technical issue, but need a lot of help. And they like the individual, in-person I want to see who's helping me. I want to make sure that you understand my needs. So we've actually changed our approach on the ground and shifted additional resources to our ground game to make sure that our DC Health Inc. Sisters, the community health centers, the advocates who've been trained and certified by us, that they have the resources from us so they can help me and help us be more successful. So that's what we learned initially. We also learned that many of our customers had terrific feedback, and a lot of it is actually very simple and doesn't require a code fix. So one small business I spoke to said, I have 2 employees. I don't want a 30-day open enrollment. It's too long for me. I can't wait that long. Why can't you just make it a week for those of us who want a short open enrollment for our 2 employees? We were able to change our IT very quickly, and after we've changed that, we've had so many more satisfied customers on the small business side. It's been incredible to watch. So even small changes, paying attention to what our individual and small group customers tell us, whatever small changes to us we can make quickly are actually perceived as a big deal change to our customers. What's more difficult for us to do is essentially anything that requires a code fix. Sometimes it could be 6 months until we can actually deploy a major change. So that's a little bit more frustrating, and until we get out of this building and enhancing mode, our customers are just going to have to be patient with us, and we'll try to accommodate them and take as many of their suggestions as possible.
Yeah, I just was going to ask, are the demographics of the folks that need the hands-on touchy-feely stuff significantly different than those who can just go through, or is it a mixture?
So the answer is we do not have good analytics yet on how the demographics breaks down for us. Because we have such a young base, our individual market enrollment, 75% is 45 and under. I mean, it's just very, very young. We think, and we have no analytics to prove it, but we think the younger you are, the more savvy you are with using an online system, and if you're really young, your attention span is very short. So you're not going to want to spend too much time.
Are you telling me as I get older, I'm going to sit there longer not knowing what I'm doing?
So for you and me, it would take more than 15 minutes to get enrolled. We also, here's what I can share with you. Our sisters are in areas of the city where individuals and families may not have a computer at home, may not have the internet. So depending on where you are in the city, you may be young and you may need to go in person to one of our storefront locations to get in-person help. We do have mobile apps that we have for both Android and Apple, and they help you locate where the closest in-person assistance is. You still can't enroll using your mobile device, mostly for security reasons, but at least you can find the closest person to you, and that's been really helpful to us.
Cool.
So I think you've raised a really important issue, which is it seems like everybody I hear from, one of the most crucial elements of the consumer experience is having access to one-on-one individual help to help answer some of these confusing questions and make some of the judgment calls that consumers have to make as they're completing the application. This year brings some really important changes in financing for state-based marketplaces and for some of the FFM states that have had the help of some federal dollars to enhance their ability to provide that in-person support. And so I wanted to just talk a little bit about what we see coming up in terms of states being able to maintain and or grow that level of consumer assistance so that people can continue to get help that they need to complete the process. I don't know where we want to start with that. Mila, if you want to start, and then maybe we can go to Kevin.
Yeah, I'm happy to. So for us, we can't survive without our on-the-ground, in-person assisters, navigators, and assisters, and certified application counselors. We figured that out early on. The messenger makes all the difference. So if, let's say, it's the Restaurant Association president saying to a restaurant, I know you can't afford to offer coverage, but can you please let these folks in so they can enroll your employees either into Medicaid or APTC, reduced premium private coverage. When the president of the Restaurant Association says that, it makes a difference and it resonates. If I say that to the restaurant owner, it's not, I'm going to be ignored. So for us, the trusted messenger on the ground makes all the difference. If we're to achieve, and the goal is universal coverage, not just near universal coverage, if we're going to get everyone covered, we need folks on the ground who are the trusted voices, the messengers, the faith-based community, and especially the community health centers and the advocates. So we're thinking through how we can shift additional resources. This year, we have a commitment to, with our assisters on the ground. Medicaid is being renewed through DC HealthLink under the new MAGI rules, and that's about as many as 200,000 people. And a portion of those folks will no longer qualify for Medicaid, so they will be joining the private side. And they will need, I think, a lot of assistance in not only how to use private coverage, but at the front end, which plan is best for them. So we have our sisters helping specifically that population, as well as some of the brokers we work with that are used to population, essentially folks who come off and on Medicaid. So we have a strong commitment. We haven't figured out where the sources might be to help support the ongoing effort, but we're trying to be creative. We're actually looking at maybe foundational-based funding to help support the on-the-ground effort. It's critical for states like us with very diverse populations, with a high immigrant population, and with a very low uninsured rate, because we've pretty much covered all the low-hanging fruit, and now it's a very sophisticated ground game to get to people who are still lacking coverage.
So actually, I'm going to switch this up. I actually want to hear from Secretary Hazel first a little bit about, I know Virginia has had an infusion of funds for additional in-person assistance and some outreach efforts this year. So maybe you could talk about what's likely to happen in Virginia next year.
That money will be gone. That's what's going to happen. Our problem right now is we are, despite the recovery, we're not seeing it so much in Virginia because of our defense industry and the sequestrations. So we have just gone through a process of taking about $800 million out of our 2-year budget, and starting 3 months into the 15 budget. So there is not a lot of money there to spend, and I think that with the General Assembly coming up into an election year, I don't see any money coming into anything that is going to support Obamacare. It's not going to happen. So I think we're going to be looking for private funding, foundation funding. We will probably go back to the administration and beg again to try to ensure that we can at least keep the folks enrolled. I think the bigger, again, I hate to come back to this, but the recurrent nightmare for us is, all right, what do we do? We have 300,000+ individuals who have purchased their insurance through the exchange. What is the court going to do? And if we had to take it over, you know, what happens in your first year? There's no more money to build it. You had to apply for that last year. There is no money obviously for the technology. You're in a first-year startup mode. How do you get self-sufficiency? And I think we're representing the majority of states, I mean, frankly, are going to be in that position. So it's not that I think it's something we need to give a lot of thought to as we go forward, and we can get to that later if you'd like, but that's really what's on my mind.
Sure.
We'll take you. We'll take you.
You want to be a partner?
We will do some negotiating later, maybe. Kevin, what are your thoughts about how we
That
can
is one option.
support the in-person assistance infrastructure to make sure that people get the help they need making their way through the application process?
Yeah, well, I think one of the things that you want to learn right from experience, and I think that one of the things we've learned is that the assister role is not a 3-month-a-year role. It's not a 6-month as it was that first year. It's a 12-month-a-year role. And I personally think that whether it's around enrollment, whether it's around renewal, understanding the coverage, understanding basic benefits and an EOB that comes in the mail, the tax issues, these are all things that assisters play a critical role in. So I don't have an answer yet financially as to how we're going to get there, but I would tell you that I feel that at our level that we have to be very committed to the ongoing support of navigators and assisters, because I think it's absolutely integral to the ongoing success of the ACA.
Agreed.
I think a lot of us here are happy to hear you say that. Just out of curiosity, I know I've run into many of you in the course of the conference who are providing in-person assistance because you're navigators or you're CACs. Can I just get a quick show of hands about how many of you actually help people fill out applications? Why are you here?
Yeah, get out and get to work. Please.
And I should have raised my hand because I should confess I volunteer sometimes on weekends in Virginia helping people complete applications.
Thank you for doing that.
So I wanted to just talk a little bit, let's talk about some of the other issues that, frankly, Kevin, you raised a couple of these issues about consumer choice. And we've talked a little bit also about what choices consumers are making, whether buying bronze plans or silver plans. And I know there's a lot of confusion that consumers have as they go through this process, and we've talked a little, people seem to know maybe a little bit more now than they did, but it seems to me that plan selection and helping people make the choices that are best for their families so they're getting the best value out of their coverage really is what's going to make the difference in people actually getting the care that they need. And I wonder if you all could talk a little bit about your thoughts about how we help educate consumers more so that they can make better plan choice selections. I don't know, who wants to start with that? Catherine, maybe?
Well, I don't have the answer to it, obviously, but it is really thorny under any circumstances, and for those of us in the room who have had the experience of doing our own choices from a small number of plans through employer-based insurance, that's not easy either. So I don't think I think we need to start by recognizing the scope of the challenge, and then from there trying to figure out, again, I think research can really help us here in understanding what are the salient issues for people, what are the pieces of information that they really want to know, and then how can we build systems that help them. So for instance, a lot of people want to know whether their provider is in a plan that they are looking at, and that is a difficult thing to tell people for a variety of reasons that we won't go into now. But those kinds of things are really issues that require a lot of attention from all of us, I think, going forward.
Mila, do you have thoughts there?
Yeah, if I can just say two things. One about the how consumers make a shopping decision. Many look to see if their providers are in the network. And I would describe provider directories as garbage in, garbage out. I would also say bait and switch
I'm shocked.
So that is one area where we have to do better. And thank you. And Claire has been helping us with that, being a secret shopper. And I don't know what state has done it perfectly. We want to do better. We've done very poorly for our customers when it comes to the provider directory. Well, one, we didn't have the functionality available, so folks would have to go to the health plan websites. Right now, we're developing a single provider directory. We're working with the Washington Consumer Checkbook, so a customer could put in their physician and get information about each of the plans the physician is in. But of course, that information is only as good as the source of the information, which is the carriers. And the carriers don't know in real time who is actually participating, who's retired, who is dead, all of the problems, you've seen them firsthand. So I'm always looking for ideas in how we can do better for our customers by improving the provider directory. That's a really big challenge for us.
Yeah, unfortunately, if this were easy, I think it had probably been done better, but we actually have a bill from one of our senior Republican senators if it passes, would mandate what has to be in the website, and then there'll be problems about what's real time, and as you've mentioned, but I think that's it. I think you're going to end up with one-on-one for a long time, and the good news about this is I think as the process, as we go through this a few more times, I think repetition is from the basis of education, and folks will get better about it going forward.
Thoughts about what you were planning to help people through this?
Yeah, well, it is complicated, right? But at another level, I think it's fairly simple, meaning that people don't want to spend a lot of time on this. They don't wake up on a Saturday morning and say, gee, let me buy some health insurance. It's not the most attractive, sexy product. They want something, I think, that they can understand and that gives that they can afford, and something they think that gives comprehensive coverage and that they can at least understand what the coverage really is and what their financial exposure is. I'm personally a little bit more optimistic that those tools are going to be, they're getting available, they're getting more sophisticated. I know that we've got some ideas about how to make networks and formularies more transparent. I agree with Mila about the challenges of keeping them updated. It's not even that, even the open panels, right? Whether people are accepting new patients or not, that's always changes in real time. But you know what? That's okay. Consumers are actually fairly patient about stuff like that. They just need to have a better understanding of saying, God, if these are my priorities, what are the best plans to go to? And we're committed to trying to make progress there. We're not there yet, but we're going to get there.
I was just going to ask a question. One of the things to me that seems critical is we look at networks and all that, but when we've looked at those folks asking the automatic renewals, not to automatically renew, but take a look again and see if your plan worked for you. Is there anything that you are doing systematically to look at how well the individuals or samples of the individuals were served by the plan they chose? That's something to me, you've got a number of natural experiments right now. You've got states like ours, or districts in states like ours right next to Mila, and we could probably learn a little bit about what people are really doing and then be able to provide the feedback.
There's a lot of research available on that type of stuff. It's not from us, but there's been a number of foundations and universities that have got data on that stuff. One of the things that we've noticed is sometimes people are renewing in plans that on the surface don't necessarily look like it's necessarily in the best interest of the enrollee, meaning that they're enrolling in a plan that's more expensive than it could be and which is having higher out-of-pocket maximums or higher cost sharing than it may need to be. So it gets back to that area about education and decision support.
Can I make one comment? This is an ongoing debate for my board's research committee. We're trying to figure out whether there is a tool out there that we can provide to our customers to help them make better decisions. And there seems to be this two schools of thought. There's the health economists who believe that people should be paying lower premiums and take on more risk, so more people should be enrolling in bronze and silver. And then there's another school of thought, mostly from the advocate community, that see what happens when patients can't pay their deductibles or can't afford to pay for their prescriptions and then skip the medicine that they need. So it would be truly a service to all state-based exchanges if foundations would actually help take a look at what consumers chose in the federal marketplace as well as in the states, and help provide some helpful tools to the state-based marketplaces to enable us to make better decisions in what kind of tools to develop for our customers.
Yeah. No, I think that's right. But I do think, Mila, that area is actually getting a little bit more sophisticated every year. You know, and you correct me, but I think insight into consumer preference and choice patterns there's a lot of data on that.
There are a number of research initiatives, and there's a good bit of science, but a lot of it is kind of slow moving and still yet to get out into the world, I think.
Yeah.
Okay, so I want to open up the floor to questions from you all so that you can join the conversation. But I would be remiss so get your cards up if you haven't already, and someone will be around to collect them. One thing I do just want to address before we do that is that we have another big test about how Americans will feel about the Affordable Care Act coming up, and it's not King V. Burwell, but it is tax time, which is upon us now. And Kevin, you've already alluded to the fact that there is going to be a great deal of consumer confusion as people navigate the process for the very first time ever of getting that 1095-A, looking at what the marketplace says they got in terms of their tax credit, and then figuring out how to fill out the forms so that they can figure out, so the IRS can figure out how much they should have gotten in tax credit, and maybe having to deal with reconciliation. And then, of course, a whole number of people who will be seeing that they're assessed a penalty for 2014 because they didn't have insurance that met the standards. And so we're going to go through this process over the next couple of months as consumers really engage with this system for the very first time. I wonder if you can talk about what you are doing to help people through what is inevitably going to be just a very confusing process and really has the potential to raise a lot of people's ire. Mila, do you want to start?
Sure. We are very worried. I'll just start with that. Next week, we'll send out our first tranche of 1095As. And then by the end of this month, all of our individual market enrollees will get a 1095A from us with a cover letter that we think is in English, but we're not quite sure. We have a bunch of FAQs that we're developing for our website. We're doing scripts for our contact center. We're preparing for a lot of confusion. And we're very worried. The one aspect of implementation that I'm disappointed with from the federal government is the IRS and the fact that they don't seem to have the resources that they really need to help educate people about the individual responsibility as well as the implications behind the APTC, the tax credit, if someone has claimed too much or too little. And so that's one area where the federal government, mainly the IRS, really needs to do better. None of the states can provide tax advice, so there are limits to what we can say to our customers. And so we're very worried about that. The one piece that we're implementing that I think will greatly help our customers is we're going to make the 1095A available electronically to them online. So if they have an account with us, they can just use their account information and download a PDF copy of the 1095A. Eventually, we'll develop an interface with Intuit. They're the folks who develop TurboTax and other providers. So if customers are using those software packages to do their taxes, it will just connect to us and populate their information automatically. We're not quite there yet. We're hoping to have that ready by the end of the tax season. But at the very least, the online PDF will be available to our customers.
Bill, do you have any special initiatives going on to help people through this?
No. I mean, I can tell you some of the thinking that way back when the discussion about setting this thing up at a state level was amongst some of the governors was that they didn't want to be the governor when the notices went out telling people that they needed to pay money back because they had gotten too much support. That actually was a consideration for a number of folks.
So, well, yeah, it's a couple things. So one is that effective last week, we began having a couple of sets of tools in the Learn section of healthcare.gov that actually help people understand the second lowest cost silver, lowest cost bronze. There's actually calculators there to actually help people. We've been sending out 1095As for a period of time now. We should be done with all of them at the end of next week. You know, the process, the other thing that we're going to be spending a lot of time on is talking about those that are going to be available for exemptions, because the ability to get an exemption, either for affordability or religious affiliation or other things, is quite broad. So I think that that's going to be very important for people to understand. You know, the process is actually not that complicated. You know, it's anything related to taxes, the IRS, and being new automatically just garners and everyone's, you know, right, like your own, right? Perception of, oh my God. But you know, it's actually not that complicated. You take a number from the 1095A, you put it on the 8562, you attach it to your 1040, it's done.
I'm sorry, would you explain that to me again?
You take the bottom number from the 1090.
No, I'm just kidding.
Intuit has already programmed all this stuff into TurboTax. Jackson Hewitt, H&R Block, all those guys have done the same. Is this going to be a little clunky? You bet. What tends to happen is the exceptions prove the rule, right? So there are going to be these outlier stories of the, oh my God, you know, I got this form and I never understood this number, or to Bill's point, I had to pay back all this money just because I understated my income. No one's paying more in taxes than they were going to pay. It's not a tax increase. So it's just, you know, it's going to get a little clunky. You know what? We're gonna ride it out. We'll be okay. The sun will come up tomorrow. We'll be all right.
Are you sure?
So our first question, first of all, I think all of us, our job is to
1-800-KEVIN.
So the first thing is, I know some of you probably may not have heard the 1095A, right? We're throwing this around like it's something that we'll know about and it's just common. And it's one of the jobs that we all have as ambassadors to consumers is to make the 1095A roll off people's tongues just like W-2 and 1090 or whatever. Anyway, we'll have all these new numbers for our lexicon. So the first question that we have from the audience actually dovetails very nicely with this topic. And it is for Kevin, and it says, will CSIO consider a special enrollment period for taxpayers who received a penalty and did not complete their taxes until after the open enrollment period, so people who file after February 15, so that they won't be penalized again on their 2015 returns?
So that is something, that's a great question. It's something that's been raised many times. It's something that's being considered. There's no decision on that yet. There's got a bunch of implications both to our system and to the issuers. Because it's all, you know, we're all in this together, right? It's a very important, you know, type of systemic relationship, but it's clearly something that interest is clearly something we're very aware of.
I have another question, and I think this is probably primarily for Kevin, but maybe you might want to weigh in on this as well. The question is really, how are appeals going? Many consumers tell us they never hear back.
Well, you know, it's funny.
I think some others of you may have had the same experience.
I periodically, it's almost like once or twice a day, I get a note from a consumer, and I got one yesterday, and you know, it was like late at night, and I write back to this guy, and he writes back. It was about midnight. He goes, "Is that you, or is that an employee that wrote back to me?" And so I wrote back to him. I said, "Well, for better or worse, it was me." And he writes back, "I can't believe, you know, somebody actually wrote back to me." So I'm not, you know, I don't know how to answer that question because you tend to need a lot of specifics. I would tell you that we've got an appeals unit and an advocacy unit that, and I'm a little prejudiced, right? They're really strong advocates for people. I mean, you talk about people that have drunk the Kool-Aid. So I happen to think that people are in very good hands when they file an appeal. Does that mean that something hasn't fallen through the cracks or something at some point? I'm sure it has. But I would just tell you that we've got a staff that's very, 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 and I'm underscoring that, committed to consumers and resolving issues.
I don't know how in DC what your experience is with the appeals process.
We have a pretty robust appeal process. In fact, we've discovered that we've had many folks who are claiming a special enrollment period, and it's quite complicated. So before we even do a formal appeal with them, we have an internal unit that looks at their particular case. And our mission is to cover everyone. And so if there's any case to be made that a person would qualify through a special enrollment period to come in after the open enrollment season is done, we err on the side of, yes, come on in. And so the formal appeals that we have aren't as significant as in other jurisdictions in terms of volume. Most of the appeals relate to whether or not a person is really eligible for Medicaid and therefore they cannot get APTC and they'd like APTC. They would prefer private coverage. The other big category of our appeals is a consumer believes that they should receive a bigger APTC amount than what we've determined. So that's a big tranche. And then we have a category of cases that should never even go to appeal because the consumer completed incorrect information and then our system said you don't qualify. But in fact, if they just checked the box that they should have, they would come straight through. So we try to handle a lot of those without the formal administrative proceeding. Most of our appeals result, we try to work with the consumer even before it gets to the administrative hearing, and our goal is always to cover as many consumers as we can cover.
Great. So here's a question from one of the members of our audience. This is, immigrants still face disproportionate hurdles in enrolling for healthcare coverage. What more can be done to help these populations access care and sign up for affordable coverage? So I wonder if you could talk about plans that you have to make the process more accessible to especially non-English speaking populations and some of the other hurdles that immigrants have been facing. I don't know who wants to begin.
Sure, I'm happy to jump in. So that's a key issue. What we've tried to do in part is to be a little bit more aggressive about working with community organizations because frankly, one of the things that I learned, and I learned this frankly in Connecticut, is that a top-down prescriptive state approach, one-size-fits-all approach, just doesn't work with communication. I remember we had a person in charge of Hispanic outreach in Connecticut, and I remember talking to her about saying, so what's the business plan? And she said, well, for which one? There were 18 different communities in Connecticut, in the Hispanic community, and half of them didn't talk to the other half. So you had to be very, very tailored and work with community leaders and community organizations to be effective within those organizations. So I think that that's one. It's understanding that it's ground up and it's not top down. Number two is to have customer service reps that are bilingual. So we've got a high percentage of our customer service reps speak Spanish. We have a language line that supports about 200 different languages. We find, Native Americans, all sorts of different populations throughout the country. I think we're doing a better job. Are we where we need to be? No. Can we improve? You bet. But we're getting there. We're getting better.
I was just going to comment on that a little bit. Again, from the research side, we have not had the opportunity yet to do the research that I highlighted earlier in any language other than English, but I think that is a real need. At least in California, we haven't seen a lot of use of the Spanish language online application, but obviously we have many people who speak primarily Spanish or solely Spanish using the English language, and so that's another piece that we need to look at carefully. I think also it's important to have an eye toward the different educational needs, not just translation needs, but for newer immigrant populations in particular, much more around how insurance works, how insurance can be used, and how care can be accessed, how to access care. Again, depending on the specific needs of the population, and that's a whole area that we have not yet, I think, as a community, been able to dig into enough.
We have a very diverse immigrant population in the district, and so from day one, when we selected our sister groups, we wanted to make sure that we had diverse groups We have significant Spanish-speaking population. We have a significant Ethiopian immigrant population, so we needed Amharic speakers, and one of our DC Health Inco sisters is the Ethiopian Community Center, for example. So we wanted to be as diverse as possible. We even paid attention to English, native English speakers who needed sign language interpreters to enroll. So we were trying to be very inclusive and very cognizant of our population. That's worked well for us. What we find is with immigrant communities, it's very cultural. And so for older generation immigrant communities, it's the personal. I want to see you. I want to ask you questions. I want to interact with you. I'll never go and use a website. My children may, but I will never do that. So we learned those lessons through our ground game, essentially. And that's another reason why we're so committed to trying to continue to fund the ground game, to continue to help customers, once they're enrolled, to actually use their benefits, especially if you've immigrated to the US from a country that didn't have private insurance and it's something new and you're learning how to use it. So it's really important to have that support system. A lesson we also learned from our contact center, we have a language line that has a gazillion different languages. And in listening, we do quality sessions. We listen to the calls that come in and provide feedback to our vendor. And we learned that they've already hired bilingual people. So actually using the language line makes the whole experience a lot longer than it should be. So we've actually authorized our vendor, our call center, to use their bilingual speakers to help people who prefer to use their native tongue as opposed to English. And that's really helped with the customer service experience and being able to offer all of our customers as efficient experience as possible.
Just a question. You mentioned your ground game several times. How many people do you actually have on the ground and versus the total population? Because I know we talk about getting 100 navigators for 0.3 million folks, and I'm imagining you got a lot more than that for a much smaller population.
So we started with approximately 200, and they are an army. They are an army. The second open enrollment, we had to scale back somewhat, so it's about, I think, a little over 100. And we're lucky because many of the community health centers also have HRSA grants and other sources of funding. So, so all we have to do is provide the ongoing training, the ongoing support, but the salaries of the person doing the enrollment is actually funded through another grant. So we've been able to leverage all available sources to have a larger army than we otherwise would.
Thanks. So unfortunately, our time is quickly coming to an end. I think the year has made a tremendous difference in the conversation we were having in this very panel last year and where we are now and the kinds of issues that we're ferreting through to make sure that we can get to that next step in progress and getting all the consumers enrolled, making sure that people are actually getting access to the care that they need, that they're able to afford that care, that they're getting the right coverage. And I assume that a year from now, we will be having an even more in-depth conversation, barring some potential upheaval that Secretary Hazel's pointed out with the Supreme Court decision this summer. But I want to thank all of our panelists for joining us today. I really appreciate all the work that you're doing to make the consumer experience and to the marketplaces work. And for joining us here today and taking your time out. I want to thank all of you who are working so hard back at home to get people signed up, many of you one-on-one, others involved in coalition efforts. Let's keep doing it, and we'll come back next year and see where we're at. Thanks very much.
Thank you. Thank you.
So before everybody heads out the door, I have to tell you about the schedule for tomorrow and what we're looking at for tomorrow so that you can get that figured out. First thing, of course, is that the next event starts at 6 o'clock and will be the reception over at the Liaison Hotel. You should have a flyer in your packet that has what is called free drink tickets. And so you might want to take that with you over to the Liaison Hotel for the reception that's going to be starting at 6 o'clock here tomorrow. One of the other things I want to make sure people are aware of is that in the program you can find out about our mobile app, which will help you keep up with the schedule. It also has a game called Health E-Action Game. And we're giving away a little gift for the winner of each day. And so today's winner is T-E-Z-L-A-D-E. Are you over there? Okay. Abby is going to bring you your gift for that, and so thanks for participating, but everybody check it out on their mobile app. The other announcements we've got are that tomorrow the breakfast will start at 8:30 in the morning, and the plenary session will start at 10 o'clock. Now, I mentioned that we have the reception tonight. There was a tradition at Families USA events that there was something called karaoke that was done after events. Well, we're not doing that this year. But in its place, we're going to be doing a 5K. At 7 o'clock tomorrow morning, if you meet in the lobby, we will start on a 5K run-walk that will go down the mall. We'll go down to 12th, and we'll wave at Families USA headquarters from there, and then we'll come back up the mall and go past HHS and wave to Secretary Burwell and say thank you for appearing, and then we'll go up Capitol Hill and thank Congress for passing the ACA, those that are still there, and then we'll go down past the Supreme Court building and wave at the Supreme Court building, and then we'll come down the Senate side and be back here at the hotel. So it will be our first ACA 5K tomorrow, and we'll meet in the lobby at 7 o'clock. And then finally, tomorrow, remember that at lunch we will have Senator Sherrod Brown speaking. That will be at 12:30, and so we'll have that event going at 12:30 tomorrow. So those are the events, those are the announcements we've got. I hope everybody had a great day. A lot got accomplished, and we look forward to seeing you at our reception, which will be at the Liaison at 6 o'clock. Thank you.